So, good evening, doctors. Today we will be discussing the return demo for suturing. Our objectives is to demonstrate proper history and physical examination of patients sustaining of an acute wound injury. We should identify the role of radiographic imaging for patients with soft tissue injuries, to formulate a diagnosis based on the findings from history, physical examination, and imaging tests, to discuss the indications and contraindications of simple suturing techniques, to discuss the basic steps in simple suturing techniques, and to discuss wound care, monitoring, and prognosis. So for our case, AD, a 22-year-old male, his chief complaint was a lacerated wound at the dorsum of the hand. The history of present illness was that a few hours to consult, the patient punched a mirror while in a heated argument with his partner. His past medical history was that he is a known diabetic, which is he's on metformin. There was no hypertension, no asthma, and no allergies noted. Family history was unremarkable. For personal and social history, he is a right hand dominant patient and he is a factory worker. For the review systems, there was no fever, no cough, no colds, no malaise, no nausea and vomiting, no lightheadedness, and there was no urinary or bowel changes. For physical examination, the patient is awake, conscious, coherent, and not in distress. He came in with an arm sling on right arm, and the patient is ambulatory. The patient's vital signs are as follows: blood pressure of 130 over 80 millimeters per mercury, heart rate of 89 beats per minute, respiratory rate of 19 cycles per minute, temperature of 36.6 degrees Celsius. So, uh, the right upper extremity, as shown in the picture, there was a 3 centimeter lacerated wound over the dorsal aspect of the second web space. It was noted that there was no active bleeding. The patient is still have full range of motion of all the fingers, and patient's capillary refill time was less than 2 seconds. So, first question was that discuss the difference between an incision wound and lacerated wound, and how would you classify the wound of the patient? So, incision wounds, these are caused by a sharp weapon or a blunt object. Sharp weapon or object. Unlike for lacerated wounds, it is caused by a blunt weapon or blunt object. So, the site for incision wounds can be anywhere, while for lacerated wounds, mostly these are seen in bony over a bony prominence. So the margins in incisional wounds are smooth, even, clean cut, and everted, while for lacerated wounds, it is irregular or undermined. For abrasions on the edges of the wound, in incisional wounds, it is absent, while in lacerated wounds, it is usually present. And for bruising, it is usually not generally seen in incision wounds, while for lacerated wounds, it is present over surrounding and underlying tissues. Next, for the shape, for incisional wounds, it is linear or spindle shape. For lacerated wounds, it is usually irregular. For its dimension, incision wounds often have gaping and longer than deep, while for lacerated wounds, it is longer than deeper. For the hair bulb or the hairs that were in the skin of the patient, usually in incision wounds, it is cleanly cut, while in lacerated wounds, it is crushed or torn. For the presence of hemorrhages in incision wounds, usually it is profuse and it can be seen externally, and it is spurting on the blood. Spurting of the blood can be seen. While for lacerated wounds, it is slightly seen, except for the scalp and external. For the depth of the wound, structures in incisional wounds will be cleanly cut to the depth of the wound. Unlike lacerated wounds, there are small strands of tissues at the bottom of the bridge across the margins. Then, for if for example incisional wounds hit bones, Bones may be cut, but for lacerated wounds, it can be fractured. For the clothes, it can be cut. For lacerated wounds, it can be torn. While then, lastly, for foreign bodies, incisional wounds, it can be absent, but for lacerated wounds, mostly it is present. So how would we classify the wound? As seen in the picture, it is classified as a lacerated wound.
For the second question, what are the structures that may be injured with this type of wound? So our patient had 3 centimeter lacerated wound over the dorsal aspect of second web space, and based on the picture shown here in the slide, the structure that may be injured aside from the skin and the fascia are the second dorsal interosseous muscle as well as the tendons that extends our digits, which are the extensor digitorum and the extensor indicis. Aside from that, the possible injured nerve supply is the superficial branch of the radial nerve, while for the blood supply, the dorsal metacarpal arteries and veins may also be injured.
So for number three, describe the radiographs. Are they sufficient as imaging? What are the other laboratory tests would you like to ask? Next slide. So for the radiograph, the radiograph of the patient is normal. The imaging obtained is already sufficient. Other laboratories that may be requested can be the CBC. Uh, Next is imaging modalities are important in viewing soft tissue injuries to know the extent of the lesion, as well as to locate the lesion and its borders. This will also enable the surgical management to be more carefully planned. Next slide. So, what is your diagnosis? So, our diagnosis is lacerated wound on the right dorsum of the hand, secondary to blunt trauma. For the salient features, the patient has history of punching a mirror. Uh, the lacerated wound is located near at the bone of prominence. For the physical examination, the patient has a 3 cm lacerated wound over the dorsal aspect of the second web space of the hand. No fractures was noted. Patient has still has full range of motion with bruising and presence of tissue bridging. Next slide. So laceration is when a sharp object or surface collides with the skin, it causes compression, crushing, and splitting. The shearing force can tear the skin and subcutaneous tissue, resulting to laceration. Blunt forces injuries can be divided into three. This is bruises, abrasion, and laceration. Next slide.
So, what is an appropriate treatment at the ER? Next slide. So, for the anesthesia, we do it early before painful procedures. It is injected through the wound, and we aim for the subcutaneous fat. Lidocaine 1% 10 mg per ml, or lidocaine 2% 20 mg per ml, with a maximum dose of 4.5 mg per kilogram. Next, please. For after the anesthesia, we do a wound exploration and cleaning of the wounds. We remove any foreign body or the vitalized tissue. It is important for reducing infection and promote healing. Clean the wound using normal saline solution or other solutions such as Prontosan or Dacan solution. We should avoid using povidone iodine and alcohol because it can irritate the wound, and it alcohol directly into the wound because it can irritate the wound and does not promote the wound healing. Next, please. For the wound irrigation, it is probably the most effective way to remove the debris and contaminants. Clean the wound area using normal saline solution with an 18-gauge plastic catheter attached to a 30 to 50 cc syringe. Irrigate 1 to 2 inches from the wound, and we use normal saline solution 50 to 100 ml per cm of laceration length. Next. We also administer tetanus toxoid vaccine. For the unvaccinated, unknown, or uncertain history, we start and complete a primer series with an age-appropriate tetanus toxoid containing vaccine. For a completed a 3-dose primary tetanus vaccination series, we we should receive 5 or more years early, administer a booster dose of an age-appropriate tetanus toxoid containing vaccine. Next. So for the primary closure, we use the primary intention done for incision, laceration that are relatively clean, minimally contaminated, and with minimal tissue loss. Next, please. We use a simple interrupted suture because it is simple and uncomplicated wounds. We also use non-absorbable monofilament suture material. Next. For the wound dressing and follow-up, clean the suture site with normal saline, apply a small amount of antibacterial ointment, and cover it with sterile non-adherent dressing. And also inform the patient to check for any signs of infection or complications every day. Next. So what are the benefits and possible complication of your chosen management? Next, please. For the simple interrupted suture, the benefits of this is it is easy to place, have a greater tensile strength, individual sutures can be removed, and with less potential for causing wound edema. For the complications, greater risk for cross-hatch marks, infections, wound dehiscence, and ischemia and necrosis.
So, what is the prognosis of the case? In case of our patient, this is only a superficial injury, so the prognosis would be excellent. And the reason behind we are saying the prognosis would be excellent is because there is not involvement of the deeper structures such as the tendon and then the bone. So, in case of our patient, so the prognosis would be excellent. Thank you.
Good day, doctors. My name is Micah Nicole A. Manala, and for today, I will be showing you how to make simple interrupted suture. But before we begin, let me show you first the equipment that's needed and how to hold it properly.
First, we will be using a needle holder. Use your dominant hand while holding it. Place your thumb finger on one handle and the ring finger on the other handle and the index finger here. For support, and hold it like this. Next is the tissue forceps. Use your non-dominant hand while holding it and hold it the same way we are holding a pen, like this. We will also be using a scissors. Put your thumb and ring finger on the handle and the index finger at the base for the precise movement and for cutting the sutures. For the sutures, you can use different types of sutures for different types of wound. And for today, I will be using a 2-metric chromic catgut sterile suture. Also, we will be using a povidone iodine for wound solution, a tape, and a gauze pad. And lastly, we will be needing a skin model or a suture pad. The area must be sanitized first, and after putting a anesthesia on the wound, clean the wound area
while using a povidone iodine for this demo.
Pierce the skin surface with the needle perpendicular to the skin at an appropriate distance at the wound edge. Drive the needle through by rotatory movement of the needle holder, recreating the arc of a circle. If the wound edges are close together, you can drive the needle across both sides of the wound. Pull the suture, leaving the convenient length at the tail end of the suture. Loop the suture away from you around the needle holder twice and grasp the suture end with your needle holder. Pull the needle towards you and push your non-dominant hand away to lay the first knot. Once the knot is tied, use the needle holder to pull the knot to the one side so it is not overlying the wound. Then make another suture knot to secure the suture. Now cut the suture between 5 to 6 mm in length. If it's too short, the knot will come undone. If it's too long, the suture material will become trapped within other knots and they will become undone. Cleanse the suture site with povidone iodine. Apply a small amount of antibacterial ointment and cover with an appropriate size, sterile, non-adherent dressing depending on nature and extent of the wound. Once you have completed suturing, you must ensure that you account for and dispose of your sharps immediately in a sharp spin. To remove the suture, get the forceps and slightly pull the suture up and cut at the knot side to avoid infections. The wound should be washed and dried, then dressed appropriately. For removing suture, the average time frame is 7 to 10 days after the suture. For the face, 4 to 5 days, body and scalp, 7 days.
And that's it. That's how to make simple interrupted sutures. Thank you for watching.